Hi, my name is Reem Boudali. I'm a fourth year peer mentor in the general lab, and today we're going to go over the Blood Products Administration CPE. So there's many reasons why you might be giving blood products to a patient, and there's many different types of blood products that you might give to a patient. There's packed red blood cells, fresh frozen plasma, platelets, and each different type will have a different reason as to why you give it. So consider your patient's diagnosis relative to whatever you're going to be giving to the patient. For example, if you're giving packed red blood cells, maybe the patient has anemia. If you're giving plasma, maybe the patient has some sort of liver issue like liver failure, maybe they have a burn or some sort of infection. So we kind of want to consider that when we are giving any type of blood products or blood components to a patient. So before we get started, we're going to cover a couple of different things. So most importantly is your blood and blood components transfusion record. So this gives you a lot of information about some of the expectations of you as a registered nurse when you're giving blood products and components to a patient. Most importantly is the fact that we need to take a lot of vitals. So you're going to be taking a preset of vitals. And the reason why we do this is to ensure that we're not putting the patient into fluid overload, or to be able to differentiate whether they're having a reaction to the blood products or if this is something that they've had before receiving this infusion. We also want to give at the start of our infusion, at a 15-minute mark, every hour, and then at the end and 4 hours post. So those are the baseline. Depending on the agency that you work at, that might differ differently. So today we have our patient Walter Whitesell, and he is going to receive some blood. So I've received my order from my physician right over here in the patient's chart, and it says transfuse 1 unit of packed red blood cells over 2 hours stat, and then to repeat some labs afterwards. So what I'm going to do is I'm going to cover my math first, and I'm going to figure out what my rate and my volumes to be infused are. That way I'm able to put it directly into the pump afterwards.
So the order that we have been given by the physician is to transfuse 1 unit of packed red blood cells over 2 hours. To figure out what this 1 unit is, we have to check our blood bag directly. This is because 1 unit isn't necessarily the same milliliters each time. It could be 250, it could be 283, it could be 187, depending on how much blood that particular person was able to donate. So once we've checked our bag of blood, we've found for this particular case, we have 250 mLs for this 1 unit. So first thing that we're going to do is we're going to figure out how much we're going to be giving in 15 minutes. Now for the first 15 minutes, according to Windsor regional policy, we only run the transfusion at 50 mLs per hour. Regardless of whatever the case is, we run it low and slow to check for any reactions. So for the first 15 minutes of any blood transfusion reaction, multiplied by our 15 minutes or 0.25 hours, we're always going to get 12.5 mLs of blood that's going to be transfused in the first 15 minutes. This will never change. For the second half of our transfusion, we have already past that 12.5 mLs, and we've already given that to the patient, and we've already passed 15 minutes. So to figure out what our milliliters and our time is, we're going to subtract those from our total amount. So 250 subtract 12.5 is 237.5 mLs, and 2 hours subtract 15 minutes is 1 hour and 45 minutes, or 1.75 hours. So because we're going to figure out our rate, we're going to take our time in hours, and we're going to do 237.5 divided by 1.75 hours, and we're going to get a rate of approximately 135.71, rounding up 136. We're going to keep these numbers aside for our pump later, and we're going to compare it. Even though the pump will do the math for us, we always want to double check.
Next thing that I'm going to do is I'm going to compare and check the MAR to see if there's any medications. Sometimes before a patient receives blood products, we might be giving them some medications. For example, in the case of GI bleeds, sometimes physicians will order pantoprazole to reduce the incidence of any ulcers for the patient. So we want to make sure that there isn't any medications that need to be transfused first. Because once we infuse the blood, sometimes they aren't compatible, so we don't want to be giving or withholding that medication from a patient beforehand. So I've checked the MAR. There aren't any medications that need to be given. then I'm going to go ahead and check my labs. So the most important lab values that we need to check when a patient is receiving blood products is the complete blood count, or CBC, particularly the hemoglobin and hematocrit levels. And this tells us a patient's blood levels relatively. It's super important in situations where a patient might have a bleed that isn't very visible to the eye. For example, a GI bleed. It's not something that we can see from like a cut, for example. So those lab values will tell us what's happening inside the body. There's different markers that kind of that kind of give us an idea of whether a patient might need blood or not. For example, for your hemoglobin, typically 70 grams per liter is the mark where a lot of physicians will say this patient needs blood if it's below that point. Again, that might depend on your agency, so always check your policy to be sure. I've also gone ahead and checked my Windsor regional policy to see the different rules and considerations that I need to make sure, including the rate, the IV compatibility, etc. So with Windsor Regional Hospital, it's super important that 20 minutes after I've received the blood from the blood bank, so I've removed it from the blood bank and I've brought it here to the floor to give to my patient, it needs to be infusing already. So the reason for that is when blood products are at the blood bank, there's special machines that help move and prevent the coagulation of blood. The second we remove that blood from those machines, the chance of the blood coagulating or hemolyzing increases greatly. So we want to make sure that that blood is moving and moving into our patient before that can happen. 4 hours is our other super important timestamp, and that is the time that all the blood needs to be infused by. After that point, if there's still any blood that is in the bag that we haven't infused, we need to stop the infusion and dispose of that because it's no longer good to give to the patient. One other thing that's stated in the policy is that we want to use an IV that is efficient for the purpose of giving blood. So typically anything larger than an 18 gauge needle is preferable for blood products. And the reason being is because an 18 gauge or those larger gauge needles have a big enough diameter to be able to infuse blood at a rapid rate if need be. So a lot of times patients who need blood, for example, patients who are in motor vehicle crashes or who are trauma cases, who are bleeding heavily or are in emergency situations, we need to get blood into their body very quickly, so at very high rates. And if we give that amount of fluid, specifically blood, through a very small space, what's going to happen is it's going to hemolyze and those red blood cells are going to break. And then there's no point in us giving that blood because it can't be used by that patient. So super important to use a large gauge needle. If you're on a floor and it isn't typically an emergency situation, sometimes we may not use an 18 gauge needle. In terms of solutions that we use, typically normal saline is the only solution that is compatible with blood products. There is mixed evidence that lactated ringers can be used, but you want to kind of steer clear from that just in case there is a reaction between the two solutions. You can always check an IV compatibility chart at your agency to check what your agency standards are. So I've collected all my supplies, disregarding the blood because that is at the blood bank. So I have my flushes, I have my swabs, I've got an extra set of primary tubing, and this is because if the patient has a reaction during the transfusion, I want to stop the infusion, remove that tubing, and then I might have to flush their body in general with fluids using a different set of tubing. If I use that same tubing and that patient had a reaction to the blood, I'm just not fixing the problem, and I'm just pushing more of that blood into the patient's body. So we want to make sure that we have a set of fresh, clean tubing aside in case there's an emergency situation. I have gloves and I have a 500 bag of normal saline that I'm going to use to prime. And then I have filter tubing or Y tubing. What's very unique about this type of tubing is it's got two different ports that'll branch off. One will connect to our normal saline, one will connect to our blood product. The clamps actually work differently for these ones. So instead of pulling them down to close the tubing, you're actually going to push them up, and we'll show you that in a second. And then it has a filter in the drip chamber. And the reason why we have the filter is to filter that blood product before it reaches the patient. So we're going to go ahead and we're going to get started. So I've already performed my hand hygiene off to the side. I'm going to open up my NS and I'm going to hang it up. And we want to make sure that we set this up beforehand because, again, once we get that blood product from the blood bank, we only have 20 minutes to get started. So we want to set up everything else that we can in the meantime. I've got my wide tubing. I'm going to close all my clamps so that when I spike, I don't spill. And we're only going to spike one side with the normal saline for now. So I've pushed my clamps up. And then I'm going to prime my line. So when we're pushing the normal saline into our drip chamber, we want to make sure that the filter is covered completely with normal saline. That way when we prime our blood later on, when it touches the filter, it won't homolicize. So that can happen if the filter isn't completely covered with normal saline. So we want to make sure that that filter is completely covered. Perfect. And then I'm going to go ahead and prime the rest of my line. And this will make it easier for the blood to move later and that it won't stick to the edge. So I've gone ahead and primed my tubing, so it's all set to go. This would be in the patient's room just to make it easier once I get back to start the infusion right away. Next, I'm going to go to the blood bank with my blood bank voucher and I'm going to get my blood products. So we want to make sure that the blood work has been done ahead of time to determine the patient's blood type, to make sure that we're not giving something that is contraindicated. So when I'm at the blood bank, I would say the patient's name and their identifiers, their blood type, and then when the nurse or tech gives me the blood that I need, I'm going to go ahead and read out the numbers to her to identify that we have the same and the correct blood product that we are giving to the patient. When I get back to the floor, I also want to double check with the nurse, so independent double check, make sure that you give the blood back to the nurse along with the patient's information, and they will double check and sign off on that as well. I want to make sure that when I get the blood bag, I want to see if it is clear, if there's any leaks, the expiry, any additives, etc. before I give it to the patient. If I receive a bag and it's coagulated, I definitely don't want to give that to the patient and increase the risk for blood clots. So I have my blood, I'm going to go to my patient's room. I'm going to hang my blood, and then with our other side of our wide tubing, we're going to spike the bag. Perfect. So once I have that spiked, what I'm going to do is I'm going to close the clamp, so moving upwards on my normal saline. You never want both of the clamps open at the same time, because what will happen is the pressure in this Y section will equalize, and that blood, instead of going down, will actually want to go up into the normal saline bag. And then you'll just have a pink bag and you lose the blood that you're supposed to give to the patient. So make sure that that clamp is closed before we open up our blood tubing. And then we want to prime the other side of our wide tubing. So we can see that now we have blood in our drip chamber. I want to make sure I have a bit more. And then I'm going to go ahead and I'm going to prime the blood all the way through the tubing. And the reason being is, as per policy, we have to stay with the patient for the first 15 minutes to assess for any adverse effects. And if we start that 15 minutes and the blood hasn't reached the patient yet, we're not doing an accurate assessment. So our 15 minutes starts when the patient first starts receiving blood. So if we have blood over here, I'm going to have to wait with the patient until I see the blood reach the end of the tubing, and then I can start the timer, and then I wait for that 15 minutes with the patient. So I'm going to go ahead and open my clamp, and I'm going to prime all the way through with my blood. I'm just using a trash can nearby so that the normal saline can go in there. So I fully primed it and I've got blood all the way to the end of my tubing, so I'm going to enter my patient's room with the rest of my supplies. I'm going to go ahead and label my tubing with just blood, even though it might be obvious to the eyes. It's good to get in the habit of labeling any type of medications that you're giving. So we're going to enter our patient's room now. Good morning. My name is Reem Boudali. I'm a fourth-year nursing student at the University of Windsor, and I'm here to give you your blood products for today. Can I just get your first and last name? Perfect. And your date of birth? Perfect. How would you like to be addressed today? Walter, is it okay if I ask you for your pronouns? Perfect. Thank you so much. So I know that the physician came in earlier because I was looking at your chart and I noticed that you did sign the consent form. So do you remember what you guys discussed? Perfect. Did he explain the adverse effects to you and the risks involved with blood product administration? Beautiful. All right. So everything's all set to go. I did want to take a first set of vitals on you just to make sure that nothing will change afterwards. Oh, sorry. Well, I'm going to put this at your bedside. That way, if anything happens, we can make sure that it wasn't something that was there before and that it's something specific to the blood. Okay? Perfect. All right, so I'm going to go ahead and get started. Just put on my gloves. I already did my hand hygiene a second ago. I'm just going to assess your IV site super quick. Looks good. Okay. I'm going to load our set in first. So I'm just going to swab your IV. And then this is a peripheral IV, so I'm only going to flush with 3 mLs. Perfect. That's all done. So now I'm going to go ahead and connect your IV. I'm going to just tape it down, that way it doesn't bother you. So the infusion is running. I'm just going to stick around here for 15 minutes. We're running it very slow to begin with, just to see if you have any reactions to the blood. And then once we've ensured that there hasn't been any reactions after 15 minutes, I'm going to take another set of vitals, and then we will change the rate, and you can just take a nap if you want. Perfect.
So I'm going to go ahead and program my pump. So yes to a new patient. And then for any of our blood products, we put just blood products. Doesn't matter if it's packed red blood cells, albumin, etc. And then for our first 50 minutes, we're going to put our rate of 50 and our VTBI, which as we discussed earlier is 12.5. And then you'll see that when I click OK, it's going to automate our time to be 15 minutes. So we know we've done that correct. So I'm going to click OK. And then I'm going to load my set in the pump.
So it's been 15 minutes, so I'm gonna go ahead. We'll pretend in a real life situation, the pump would stop on its own, but because we're not gonna actually wait the 15 minutes for this video, I'm gonna go ahead and I'm gonna stop the pump.
So what I'm gonna do is I'm going to click stop for now, and I'm gonna click review. And I'm gonna go up. I'm gonna avoid changing my rate because as we saw with our math, our rate turned out to be a very long decimal. So I'm going to let the pump auto-calculate that, and I'm gonna start with my VTBI, which we ended up finding was 237.5. I'm going to round that up to 238. And then I'm going to go back up, and I'm going to adjust my time. We already did the 15 minutes, so now we only have an hour and 45 minutes left. So now I want to put 1 hour and 45 minutes. Note that this isn't fully an hour, so I'm not putting 1.75. I'm putting 1 hour and 45 minutes. Perfect. And when I click OK, it's going to ask me, hey, you're changing the rate to a significant amount. Are you sure this is what you want to do? And this is where I'm going to look back at my math and make sure it's somewhat near. So it's telling me you want to change your rate to 136. I'm going to check what I calculated, which was 135.71. That works for me. I click OK. It's double checking with me, hey, you're changing the rate by a lot. Are you sure you want to do this? I click yes. And then I go ahead and restart my infusion.
So now we're running at our final rate. That's just gonna run for another hour and 45 minutes. I'm gonna be in periodically to check your vitals and make sure that you're doing okay. Your call bell is right next to you, so if you feel funny at all, like you feel like you got some chest pain or anything, you're feeling a bit off from usual, please don't hesitate to click that call bell and let me know as soon as possible because there might be a reaction to the blood products. Right? Perfect. So I'm going to go ahead and I'm going to chart that on my blood and blood products components record. Hi Walter, so your blood transfusion has been complete. I'm just going to go ahead and disconnect you and flush your line, okay? Just swabbing it off. Oh, sorry there. Perfect. All right, you're all set. Do you feel okay? Awesome. All right, so we're going to be back in a bit just to retake your lab values and make sure that that blood worked and did its job, okay? Perfect. All right, take care. So in the case of an adverse reaction, the first thing that we ever want to do is stop the infusion completely. Next thing that we want to do is we want to discontinue the tubing, so we want to disconnect it from the patient, but you don't want to toss it. If there has been a reaction, we want to send the tubing, we want to send any extra blood that there is back to the blood bank so that they can analyze that blood to see if there was an issue with the blood itself or if it was an issue between the patient and the blood. We always want to assess the patient, so you want to check on them, stay with them, and then call the physician while you call the blood bank and all of that to see if there's any other action that we might have to do. The physician themselves might order specific things, like they might ask you to take a urine sample to look for hemolyzed blood. This would show up in the lab values as hyperkalemia, so an increased potassium. They might order some meds like antihistamines or steroids to suppress that immune response, some fluids to kind of flush the body, antipyretics to decrease the fever, and vasopressors like epinephrine that we give in an allergic reaction. So you might want to expect those if the patient is having an adverse reaction. It's also highly recommended that you understand each type of adverse reaction to blood transfusions, as well as their signs and symptoms, as it can help you identify them easier.